So, iron overload. First, I'm again leading with a case history. This one's fictional, but it's typical. We get an awful lot of referrals for significantly elevated ferritin, not just, oh, it's 650, more like it's 2,000. And it's very hard to just ignore those. So I've called him Mr. FE, why not? But ferritin 1760, that would be fairly typical. Key thing, normal transferrin saturation. So immediately you kind of go, oh, it's probably not, but let's test them. And then you test them and they're negative for all three of the mutations we test, the molecular tests. He's got intermittently deranged LFT, so that could be the cause or the result. He's got an elevated BMI. He's got diabetes. He's got dyslipidemia, and dyslipidemia. Very importantly, he's got a negative family history. I really urge you, it's a good time to, when you're seeing somebody with the high ferritin, is to just explore if anyone in the family is on venesection or has been diagnosed with iron overload. And if it's negative, that's another strike against them. So I also look at the pattern. So if they've got a sort of roller coaster pattern to their ferritin, it suggests it's an inflammatory cause. If it's actually getting better and better, that's really suggesting they're not steadily accumulating iron. On the other hand, if it's just inexorably going higher and higher, that's suspicious for true iron overload. So his had been consistent for 5 years. He was normal for the genes. He's non-Caucasian. That's another clue that he's less likely to have hereditary hemochromatosis. And normal CRP isn't much help, I find, because it can be intermittently normal even when there's an underlying inflammatory driver. So have we excluded hereditary? Not completely, but it's a lot less likely. And if it's not inherited, could he have some other cause for iron overload? Yeah, possibly could have. Can we just monitor him? And that's the big question. So let's quickly remind ourselves of classic hereditary hemochromatosis. The first thing that happens in young adulthood is that their transferrin saturation goes high, even before the ferritin's high. Then the slow progressive rise in ferritin, and the symptoms are classically morning fatigue, which is usually relieved by treatment. It's an amazingly reliable symptom when present. Arthralgia, typically the painful handshake, small joints, and much more rarely skin bronzing and hypopituitarism. So the organs more or less in order are that may be affected: the liver, the small joints, pancreatic islands, heart, pituitary. So bronze diabetes, which I've seen all of one case of, and you can see the CPPD and the bronzing. And so 90% of cases are homozygous for this particular mutation. The other mutations are weaker causes, but you could get somebody who's got one allele for that mutation, one for that, i.e. they're a compound heterozygote. In case anybody's forgotten their biology, this is a heterozygote. And the patient steadily overabsorbs iron, damages the liver, they get bridging fibrosis and eventually cirrhosis, and they're at risk of hepatocellular carcinoma. That's the whole thing. We're trying to stop target organ damage. And the treatment is venesection. So that's classical. We can kind of put that to bed. This guy, we haven't really. First of all, there are a lot of other HFE mutations which we don't test, and if he's in non-Caucasians, they may be bigger players. Secondly, there are other genes other than HFE which can also be mutated. HJV is hemojuvelin, so those would present in childhood. It can be challenging to diagnose. You can, or we can, send a sample to Blueprint in Helsinki to be sequenced. That's Shop of Ireland, where 1 in 4 people in Dublin are heterozygous for C282Y. Ferritin's raised by two things, as you know. It's either by total body iron stores or inflammation, and we don't know which one is the cause here. We've got a lot of clues. So those are all the sort of signs that it might be genuine. And then you look for other possible causes, and he's got quite a few of those: diabetes, BMI, hyperlipidemia, LFTs, alcohol, and perhaps hepatitis as well. But the problem is the third group, where they're genetically negative, there's no family history, but also they don't have any of the usual suspects just listed here. They're relatively slim and fit and non-comorbid, and they've got a pesky high ferritin with normal transferrin saturation. We've got, first of all, the trial of venesection. If it takes less than 12 units to de-iron them, then they probably never had proper iron overload. But of course, if they're quite young, it might have been that if you left them untreated for another decade or two, they got iron overload. We really need an age-adjusted way of looking at that. And then at Middlemore, we can do a quantitative MRI, but of course that's not widely available. And the problem is it doesn't tell you which cells the iron is in. And here's the thing, if the iron is accumulating in their hepatocytes within the liver, then they're at risk of liver damage. If it's just sitting in the normal storage cells in the liver, then it's non-toxic. And it would be good if we had a way of discriminating between the two, but we don't yet here in New Zealand. And again with the MRI, even if it doesn't show iron overload, if they're young, it might have been just a matter of time until they did. And then you can do a liver biopsy. They won't thank you for it, but it at least tells you, one, do they have bridging fibrosis? And two, which cells is the iron in? So at the moment we're sort of busted back to having to consider that in some circumstances. It's not a good measure of total liver iron because liver iron is quite patchy. And of course, fibrosis might develop down the line. It is quite a painful procedure. So this is a real patient. And as you can see, they were genetically negative, they had high ferritin, they had normal transferrin saturation, they had high liver iron, they had a positive family history, and they were non-Caucasian, but there was clearly a genetic hemochromatosis in this family. But that's pretty rare. I mean, I've sort of got only a couple of families in that situation. He did require 12 units venesection, and he got symptomatic improvement. That's the other thing. If you venesect them, you de-iron them, and they say, oh, I'm not tired anymore, this is great, then that's another reason to continue. So in summary, there are three groups, as I've said. There's the clearly hereditary group, there's the clearly secondary inflammatory ferritins, and then there's the no clear cause group. And they may have a family pattern, and they may warrant referral, and we sort of come up with a plan. This is back of an envelope, so probably don't even photograph it. The existing pathway, if it's classic, then if they're heterozygotes, so you think, well, maybe they do need treatment, they refer them into haematology, and we can do the MRI and so on. And then the HFE unmutated. So if the ferritin's persistently high, then probably, or I guess the liver is persistently abnormal, refer them in. But if not, then I would complete any missing screening, check for all the other causes that could cause a high ferritin. And if the LFTs dominate the picture, maybe refer them to gastro instead if it's predominantly, I'm not trying to avoid work here. And gastro can potentially do sonography, in other words, like a elastography to see whether they've got fibrosis. Otherwise, you can, if they don't fit any of those categories, I think it's safe for you to monitor their ferritin and their LFTs, and when they tick any of these above boxes, then re-refer them.